So I'm now going to welcome the next keynote speaker to the stage. It's Minal. Dr. Minal Bakhai is a practicing GP and NHS England's Director for Primary Care and Community Transformation. She leads major national programmes, including Modern General Practice and the National Neighbourhood Health Implementation Programme. Minal advertises government internationally and was awarded an MBE for services to general practice. Her talk is on From Vision to Action, Turning the Dial on Neighbourhood Health. Please welcome Dr. Minal.
Hi, everybody. Lovely to be here, and thank you for that lovely introduction, Chris. I'm hoping that you can see my slides. Brilliant. Thank you. So I'm going to tell you a little bit about the work I've been doing around the National Neighbourhood Health Implementation Programme. So I think, first of all, just to start off and probably echo a lot of what my colleagues have already been saying, is that neighbourhood health is not new. It's been a policy ambition for about 5 decades. And I have the privilege in my role to visit lots and lots of places that are progressing neighbourhood health, but my reflection is that many of them have managed to progress despite of rather than because of the system that we work in. And so while we've had this policy ambition to move care closer to home towards more coordinated, personalised, integrated care, actually, what we've seen is the reverse. So we've seen resources flow in the opposite direction, as Lord Darcy's report articulated really clearly. We've seen over the last decade growth in hospital funding by about 21%, but a decrease in community funding by 4%. We've seen an expansion of our specialist workforce, so hospital consultants again grow by about 168%, but we've seen a reduction or a shrinkage in our more generalist workforce, the workforce that we're going to absolutely need to care for an ageing, multi-morbid, more complex population. So nurses, GPs, and so forth. And so we've seen a 7% reduction in GPs over the last decade and a whopping 50% reduction in our district nursing teams. And so I think I always like to take a moment just to reflect and think about, well, what are the lessons that we can learn from previous large-scale change initiatives that have gone before us that have been trying to drive this same ambition of the left shift? And so some key reflections for me are that often change or success of the change has been seen narrowly through the lens of the NHS. So very quickly, it's rapidly, narrowly focused on hospital activity rather than whole person outcomes. Secondly, change has been seen as a technical and a linear change when we know that this is complex, it's adaptive, and it's absolutely predicated on trusted relationships. And so that impacts the pace of change and how quickly we can move. Thirdly, the pace of change nationally hasn't kept up with the pace of change locally. So regulation, performance frameworks, funding flows did not keep up with the hard-won changes that were made on the ground. So they were not hardwired in. And so then when you have a change in leadership, for example, it can make it much harder to move forwards and often much easier to move backwards. And then finally, and I'm sure we'll talk about this a lot more here, is data. So not only do we need data and data sharing and integrated data sets to work in a more integrated operational manner, but we also need that data to do the detailed work of really understanding what does it cost to shift left, what are the interventions that make the biggest difference, and how do we collectively then see those outcomes that we want to see. And so for me, we have to take these lessons that we've learned from the past and really embed them in how we move forwards as we start to embed neighbourhood health going forwards. I'd just like to say I'm in my practice today and they have put the light sensor in my room far away from where I actually sit. So I have to keep moving my chair to get the light to turn back on. So apologies for that. So the urgent case for change, well, I think we all know why we need to change, but actually, as a frontline practitioner, I really do feel that this is our last chance to translate ambition into action. Over the next decade, we're seeing a rise in demand and complexity. We're going to have 68% of our over 65-year-olds suffering with multi-morbidity. And we're seeing a rise in long-term conditions and multimorbidity happening at a younger age. We have a widening of health inequity. So there's a 20-year gap in healthy life expectancy between those living in the poorest areas and those living in the affluent areas. Most affluent areas. Now, I'm a GP in a very deprived part of London, and actually that is very much my lived reality for the communities that I serve. We know that population health outcomes have started to stagnate, and actually they're starting to fall for cardiovascular disease in men. And we know that we're seeing increasing a rise of dissatisfaction in our workforce. So the last NHS staff survey showed that 41% of NHS staff felt stressed, tired, burnt out, primarily from working in a system where they felt disenfranchised, that they weren't able to do their best work, where they were being asked to prioritise task completion over care and connection. And then that's further exacerbated by an ever-increasing churn of short-term initiatives and short-term funding cycles, which makes it really hard to embed change. And I think we all recognise the financial pressures we're facing across the public sector. Currently, we spend about 40% of the public sector budget on the NHS. That's projected to increase by at least 0.6% year on year. So in 30 years, that's 60%. It's really unlikely we're going to have the support of our public to spend such a large chunk of our public sector budget on the NHS alone, and particularly when it does not feel like it's delivering for communities. So that it does not feel financially sustainable to continue on this road. And therefore, it should come as no surprise to all of us that when we look at this data, 15 years worth of data, looking at emergency admissions, while we can see a small inevitable rise or non-mitigatable rise in emergency admissions related to increasing complexity in an ageing population, we see an exponential rise in avoidable or mitigatable activity. So our most cost-intensive, resource-intensive part of our system, there's a huge amount of mitigatable activity, and that is linked to a disinvestment in primary and community services, but also, really importantly, the social infrastructure and community infrastructure where people live, which is absolutely critical for prevention and health creation. The importance of feeling connected to your community, feeling connected to your place, and feeling connected to purpose are the fundamentals of what drives good health. And this is just looking at more data about projections of the future. So I mentioned that a majority of the demand that we're going to see over the next decade is driven by multimorbidity and long-term conditions. I absolutely am seeing this as a GP. But 80% of multimorbidity starts with 8 gateway conditions. And the evidence shows that if we can better manage those 8 gateway conditions, either prevent them altogether, diagnose them early, or manage them more effectively because we've diagnosed them early, then we can slow down the pace of multimorbidity, which we're seeing start at a younger age. It's more pronounced in areas of high deprivation and in ethnic groups. But also, optimistically, there are 4 key modifiable risk factors that underpin all of those conditions: smoking, alcohol, physical exercise and diet. And so if we can start to address these, then we have a really good, strong fighting chance of bending the curve. But I think we also all recognise that 80% of health is determined outside of my four walls of my clinical room or the hospital. It is determined at home. It's by the wider social determinants of health where people live. And so the NHS cannot do this alone. It has to be a partnership approach. And the strengths of partnerships is going to be absolutely critical in driving this forwards. And so the National Neighbourhood Health Implementation Programme takes a radically different approach from change efforts that have gone before us. Fundamentally, it recognises that health is wider than health care and that 99.9% of health happens at home. And so really a core component of the programme is investing and building those trusted relationships and those strong partnerships and recognising the strengths that different partners within a system bring. And that is not just statutory partners, that's absolutely non-statutory partners, the voluntary sector and communities and community leaders themselves. It's a large-scale change programme, so it's not about piloting and spreading. It's taking the existing knowledge, because there is 50 years at least worth of existing knowledge, and building on that and spreading that systematically across multiple places around the country. And it takes a tight, loose, tight approach. So tight on a shared mission and shared accountability, tight on some shared outcomes, whole person outcomes, and actively learning from each other, but loose on implementation, because we know there's no one size fits all, and that these interventions will need to be adapted to the local context. And it's about creating the enabling environment and conditions for change, not just the what and the local changes on the ground. And so it's connecting teams. We've got 43 sites in our wave one, connecting them back to national policy and programme teams. So identifying the blockers and the barriers that practically get in the way from progressing this change and connecting them back up to national policy and programme teams to co-produce the solutions, while also recognising there are some key fundamental things that we need to do to hardwire these changes and shift left system-wide properly. Things like funding flows, performance frameworks, outcome frameworks, contracts, and again, co-producing those with those that are delivering the change on the ground, so that we're connecting policy and practice really tightly together. I said that it's outcomes focused, and I'm going to come back to that in a minute, but I just really want to stress that we are looking at whole person outcomes. So we're looking at beyond just the service utilisation metrics within the NHS, but those wider factors that are important to people. So going really to the what matters to you conversations. And then finally, recognising that health is a horizontal, and it is wider than the NHS and the Department of Health. And so working across government, so working with the Cabinet Office, the Office for the new Office for the Impact Economy, MHCLG, DCMS and others, who are all investing in community regeneration, community infrastructure, social infrastructure, and therefore being greater than the sum of our parts. And one of the key reflections that the 43 sites have played back to me is that they absolutely recognise that this is about a mindset shift before anything else. So this is about moving away from body parts to whole person care, but not just looking at individuals. It's also looking at households, because as a GP, I look after families and households. I don't just look after individuals. These things are all really interdependent. Secondly, it's moving away from a deficit-based approach to one that is strengths-based. Thirdly, it's about moving away from a culture that asks, what is the matter with you, to what matters to you, doing with, not doing to. And why is that important? Because when I ask my patients, what matters to you, I really understand how their symptoms are playing out in the context of their family, their household, and where they live, in the context of their lives. And through that, we make higher quality decisions, because I can see more, I can ask better questions, and collectively we make higher quality decisions, personalised care decisions about, therefore, what are the interventions that are going to make the biggest difference to those individuals' lives and their families' lives. And as we start to see more, as a system, we can be more agile and do better. And as the seeing and the doing fits, that's when we move to value-based care. And that's really at the heart of the 10-year plan and everything we're trying to deliver. And I just want to say there is a huge amount of motivation and momentum to do this and do things differently. When we put out the EOIs for the NHIP, we received 141 applications from 144 places across the country. That's 83% of the whole country recognise that we need to do things differently. And so we are not just doing the what. This is about shifting mindsets and thinking differently. It's then about doing differently, working differently, and I'll come on to that in a minute. It's then about delivering differently. It's about measuring differently. And then it's about hardwiring those changes. So, I have, as I said, had the privilege to visit lots of places that are progressing neighbourhood health, and through structured interviews, visits, and then testing with 300 key partners across the whole of the health and care system, we distilled down what the high impact actions were that really helped turn the dial and enable places to see the change, because otherwise this can feel quite overwhelming. And there were 4 key high impact actions. First was using our data, our shared data, as well as local community and intelligence, practitioner intelligence, to identify those adults with long-term conditions who are at high or rising risk of escalating need and hospitalisation. It's then about coaching practitioners to systematise a different way of working, that shifting mindsets that I mentioned, to help activate people and support them in the co-management of their long-term conditions, working with activating the resourcefulness of individuals, families and carers. And when we ask people about how confident do you feel about your managing your health conditions, your health and well-being? And then we ask them about what's the one thing you could do tomorrow that would make the biggest change in activating activating you. 90% of the things that people come back with are nothing to do with the healthcare system. They are, I feel socially isolated, it's my housing, it's my financial instability, it's mental health, but related to being lonely and not feeling connected, or connected to purpose. So this really starts to open our eyes to where we need to drive the investment. And of course, technology, we can leverage technology to really help us do that now. Then it's about coordinating care around individuals and neighbourhoods. We're named multi-agency team of teams that provide proactive and reactive whole person care 24/7. And we start to rationalise some of the overlapping functions we have in the systems. I visited places, some places have 70 overlapping functions. So while we absolutely recognise there are all the funding constraints in our system, actually, there are opportunities here to allocate our resource differently if we start to see the whole, what matters to people, and then be able to coordinate all of our assets differently. And then finally, but really importantly, it's about building those deep community relationships, particularly with those where we've lost trust. And this is a big issue, not just for the healthcare system, but for the state and communities more widely, and is key to public sector reform. But how do we rebuild those relationships with communities where they feel disillusioned by the public sector not delivering for what they need? And there's brilliant work happening across the country. Community health and wellbeing workers allocated to the 20% most deprived households, knocking on their door. They are trusted, they are culturally competent, they are part of the community, but they are also part of our workforce, and they provide that bridge. And they help them with people with all aspects of their lives. But they also then bring them in to see me as a GP when they're worried about them, or where there are worrying symptoms, but people don't feel confident to access healthcare. So we can start to do that early diagnosis and early intervention that I mentioned before, and also connect people more widely. But the what is very important, but the how is just as important as the what. And so, as I said, this is about building trusted relationships, strengthen partnerships, but fundamentally it's about a different type of leadership. It's permissive leadership that dissolves the bureaucracy that gets in the way for people doing their best work. and dissolves the power imbalance and allows people to be creative. And I have given our 43 sites 2 rules. Don't break the law and don't make things worse. Otherwise, do things differently. And I'm proud to say that in some of our sites, we've got rid of the F word forms. And sometimes when systems are under pressure, actually bureaucracy can make it worse because we add in more thresholds to access care, more referral criteria, more forms, more process. And that gets in the way of doing the best for our patients. And so this is about having that permissive leadership to dissolve some of those old habits and shape new ones together. But it's also about having that relentless focus on outcomes. So it's working differently with communities, involving them from the very start, ongoing dialogue, not just one-off engagement, and truly embedding co-design of outcomes, co-delivery of services, co-learning together, and having that transparency and accountability with communities. And so some of the key outcomes that we're capturing through the NHIP are patient-reported outcome measures, patient-reported experience measures, people's activation, staff experience, as well as service utilisation measures, so outpatient activity, unplanned hospital admissions, length of stay, and general practice activity as well. And why this is really important is that when somebody is socially isolated, when their care is poorly coordinated, or they have deficits in their well-being, they are far more likely to end up in hospital through an emergency admission. So we have to look at the whole if we are to solve some of the NHS's most complex challenges. And therefore taking that wide whole person view is not just a nice to have, it is absolutely critical to solve the problems that we're trying to solve. And then really, I'm not going to go into this in too much detail, but these are just examples of places that I've visited that have been driving the high impact actions that I described. And I think it's just to say that recovery and reform, we see them as silos at the moment, and actually they're 2 sides of the same coin. And we have to bring them together. And we can't have a phase 1, which is recovery, and a phase 2 that's reform. They are 2 sides of the same coin. When we do things differently, when we work through neighbourhood health, we see huge reductions in emergency admissions, ED attends, ambulance calls, medicines optimisation, general practice appointments. We're reducing pressure on the system, but we also see a huge improvement in people's activation, well-being, and their engagement in screening and immunisations that all lead to better population health. So I'm going to stop there. I think my final reflections are that this is complex work, and capturing those outcomes is a real challenge. It's a challenge because, this isn't something we've traditionally done. We've made some huge impact nationally with building the infrastructure, what we're calling the National Neighbourhood Health Integration Index, where we can capture PROMs, PREMs, person activation, and now link it directly at a patient level to service utilisation data. So that's something we would like to work with the analytics community on refining further, testing and refining further. We have 43 sites across every single system. So I would really value your collective contribution, working with your sites, your local sites, to help them move this forwards. The third thing is that we also need to start linking whole person outcomes and whole person interventions, so we can start to understand which interventions are having the biggest impact on those outcomes. But like I said, it's not just the what, it's how you deliver those interventions as well, and having those what matters to you conversations and personalised care conversations and coaching conversations. So how do we understand whether that's happening or not? And then, of course, the data quality and the coding to be able to track all of that, and the data sharing to track the whole end-to-end journey is going to be really important. And we're doing a lot of work with the strategy unit, who are our partners in this, in thinking then about the counterfactuals and how we identify the right counterfactuals to understand, you know, what would have happened if we hadn't done this, but recognise that the system is not static and it's dynamic, and there are always new initiatives that are being embedded. And so how we do that is also really, really important. And then finally, so much of this is behavioural. So to see the macro changes, even if we do reduce and turn the dial on emergency admissions and some of those metrics for the target cohorts that we're looking at, we have seen through other data that actually there's a substitution effect, and people's thresholds for admission can sometimes drop. Or actually the strain of flu virus that year was particularly bad, and so there was an increase in demand more broadly. So I think it's complex analytical work that we're going to need to do here to really do that detail that I think has hampered us for the last 50 years to drive the left shift. And so really it's an ask for help and a connection to our 43 sites to help us really move some of this thinking forwards. Thank you. You're on mute, Chris.
Sorry, I'm on mute. You'd think I'd never done this before. Thank you very much. Really, really interesting talk. There's lots of questions. We're not going to get through them all, unfortunately, but I will do my best. Here's one. I'm going to try and share them on the stream. Let's see how well this works. Yes, here it is. Do we have a definition of what a neighbourhood is?
Yes. So a neighbourhood is based on geographies. So it's first of all, it's what communities would recognise as being their neighbourhood. It's coterminous geographies, but we're saying on average a neighbourhood is between 30 to 50k, but it's more about the geography and that communities would recognise that being their neighbourhood rather than the size. Because, for example, there are some neighbourhoods in rural areas that are 5,000 and some neighbourhoods in more urban areas that are bigger than 50,000. So the number is less important than actually it is what would be defined by communities themselves as neighbourhoods. And some of the work that's happening between now and the end of the year are places and systems working together to identify what those neighbourhoods look like. And in many areas, they're similar to the PCN footprints, but in some areas, that geography doesn't quite make sense.
Thank you very much. Here's another question. Let me just pop it on the screen. How can we do analysis into some of the outcomes we want to see from neighbourhood health beyond healthcare use, which we often rely on as it is easiest to measure?
So, I mean, what we have started to do, and I'm not, this is a journey that we're on, so I think the first step was actually building a mechanism to capture PROMs and PREMs and person activation consistently across the country. So we've got that. We've got through the IG challenges to make sure that we can link that at a patient level to connect that to service utilisation data. So we have a mechanism to take burden away from places. We have a mechanism to do it consistently, and we have a mechanism now to link it to patient level data, utilisation data. That's the starting point. But we're going to have to continue to refine this. So, there's lots of things that we will want to do to be able to isolate what were the key interventions, for example, that had the biggest effect on activating people. So increasing person activation. And some of that is going to be really understanding what the interventions were themselves on the ground. So I mentioned what the high impact interventions are, but there's always going to be a combination of things that's happening on the ground. So coding, and this is where the partnership working comes in really importantly, that kind of clinical policy analytics partnerships, because it's about understanding the operational processes and what's happening on the ground, linking that to what, we're trying to do from a policy perspective, and then linking that from an analytical angle. So I'm not sure that fully answers the question, but I think we're in the process of capturing that information to then do some of that analysis And so I think some of the challenges will arise when we get into the analysis itself.
Absolutely. Well, it's a conversation, as you say. Well, we're going to have to wrap it up. There's loads and loads of questions in the chat, so it's really nice to see all the interest. Do engage with the Q&A afterwards if you have time, please, Minal. Thank you very much again for an excellent talk. We have now moving into lightning talks in the other streams. I'm not going to read out what they all are, but do go on the program. There are 4 other streams with lightning talks starting now, so do go and enjoy that. And then we're going to break between 10:55 and 11:15. So we'll see you all soon. Thank you very much.